We're going to please begin to line up if you have questions, but I wanted to start with one comment and then ask a few questions of the panelists. My first comment is we're having a lengthy discussion about the importance of return on investment, but in fact, most of the time, in terms of the services that medical services that get approved for reimbursement in the healthcare sector, there's really no real return on investment that is done, as demonstrated, I think, by the incredible high-cost services that are offered at end of life when, even the science would say there's a very slight chance that this will result in extending the life or quality of life. But that's no question there, that even though those are incredibly expensive. So I just want to recognize that it's a high standard bar. It's a special high bar that exists when we begin to talk about the social needs of patients and periodically making the case that is a double standard, I think, is fair to do. Maybe I'd start just by asking the two of you who are here from both public and private insurance, maybe we'll start narrowly thinking about return on investment, not quite get to the wrong pocket, not quite get to the broader social needs, but just thinking in terms of your own internal decision making. Seth was saying, that you could, in a clinical setting, you could, or for an insurer, you might look at costs, certainly, but maybe you're looking at utilization. Maybe you'd look at certain quality metrics. Maybe you'd look at patient outcomes, reported patient outcomes. Could you just talk about, within your own organizations, are there specific returns that are used as the criteria for making a determination about approval of a new benefit?
I think there's a couple pieces. I mean, you hit on costs and utilization as the big ones. I think we have an unfortunate situation where we have a lot of great interventions where we have data on self-reported health, on all sorts of measures that probably tell us something about the intervention moving in the right direction, but don't get there. I also recognize that we at CMS have a role to play, and that often, you need very big numbers to be able to look at utilization and outcomes, and I certainly hope that Accountable Health Communities model will help us get some more of that data. I think another issue when it comes to really thinking about new coverage does relate to actually a question that you asked earlier, John, in the other panel about sort of certification. We have to think about things like, how do we recognize which providers are qualified to offer, some sort of service? How many minutes do we think that service might take? Or, how do we figure out what is a reasonable payment for that service and all of those pieces? So it definitely makes it easier for us when someone has kind of standardized, this is what the intervention is. And I think that's also a tension in this area because we want to be sufficiently modifiable and flexible that things can work in different community settings and communities with different resources. But we as CMS also need to be clear on what it is we're paying for. And so we need some structure around the intervention as well as the data on how it impacts utilization.
I think it's a really great question. It's a very important question. So I think two things. So one is defining what return means, and there will be different important returns depending on who you're talking to. So to the CFO of a payer, the financial returns probably are what that person's looking at. But to the clinical team, the clinical returns, is the return in terms of health? There are returns in terms of are we getting closer to reaching our mission? And so these different, defining the return specifically as you're building this ROI is really important, and then articulating that to these different entities is also important. And it also speaks to this point about if this intervention reaches the mission or the value of this leadership team, there can be a negotiation. Well, okay, there's not major ROI here in terms of the financial argument, but look at how this helps us reach our mission, or look at how it improves health. And so then that whole package can come together. And having all of those points clearly laid out so that then you can go and make everyone who needs to see their point being met and being flexible in that way is really important.
So George, just hold on one more minute, because I have one more question for the two of them before we turn to you. The next question is really the temporal question, because I'll share with you that I was formerly a state public health commissioner, and we had very good data that showed a return, both savings in healthcare as well as positive health outcomes if people, if insurers paid for all of the FDA approved smoking cessation benefits. And so once Medicaid had shown that, I went to one of the commercial payers, a terrific person, really like a very altruistic person who headed up a commercial insurance company, and said, well, you'll cover this now, right? Because we've got the data. And what she said was, well, no, she said, they won't develop, they wouldn't have developed lung cancer within a 2 or 3 year period. I only have them for a limited amount of time. Any investment of mine up front, the savings will accrue to Medicare, and therefore, even if there is a return on investment, it's not one I can capture, because I'm forced to think in terms of the limited time that I have someone enrolled in the insurance company. Is that a consideration? Is there an industry standard for the number of years, or what do you think the range is as people grapple with that kind of issue?
That issue frustrates me incredibly, and it also argues for what funding entity will see this person over the course. And so could you make that argument, for example, to a state where the cost savings, even though you've got Medicaid and you've got other sectors that they're paying for, where you could argue that the savings, even though this person may be on or off of Medicaid, that you'll still see the savings in a different sector, for example. And then there are some payers where people do stay on for longer. And there's less of that turnover, and so that's a place where it is easier to make that ROI analysis. But it absolutely is true that if you make this investment, you're not clear that member is going to stay on, and that's a major challenge.
Yes, I have a list of like the most depressing things that people have said to me, and that motivates me. And this is one of those issues. And yes, certainly in, for example, Medicare Advantage, there tends to be longer times when someone is with a plan than in many other settings, and that And for Medicare as a whole, we have a very long time horizon. But I think the short answer is that I'm not aware of an industry-wide standard. I think it varies a lot across payment models. At CMS and for our models, we are typically looking over a 10-year period.
Great. George, you have an even harder task, because they were talking about within an insurance framework with where you might be able to actually capture the savings and demonstrate that. And you were illustrating the research that you're doing that takes into account things like future employment and taxes and productivity, perhaps. And so I guess maybe this is a provocative question, but does anyone care about that? I mean, I think people may care about it philosophically, but have you ever met a policymaker who takes that seriously?
Maybe you should ask other people in this room that question. It strikes me that people should care about that. Yeah. That health systems, for example, can cooperate, presumably, if they understood who's benefiting from these interventions, with government, with other stakeholders, employers, in order to collaboratively find ways to invest in these interventions that everybody agrees are a good idea globally, but no one stakeholder has a significant enough return on it that if you care about financial return, you're not going to be inclined to invest. And I think the answer is to get cooperation among various stakeholders. Len Nichols and Lauren Taylor have developed, they haven't developed actually, they've adapted an old economic model to attempt to do this, where they have a trusted broker to whom stakeholders tell the trusted broker how much they're willing to pay as a part of this investment. The trusted broker then adds all those up, and if the total seems to exceed the value of the investment that they're talking about, then he can go back to those stakeholders and say, okay, none of you has to pay as much as you thought you were willing to pay, because the total expense is higher than, total money available is higher than the cost of the investment. So here's how much we will ask you to pay to be a part of the team that invests in this. And I think that they're working toward actually fielding that now. It was described in a health affairs paper, I think, last summer, but they're working now toward trying to field that and actually test to see the extent to which it can work. And I think it's a pretty interesting way to perhaps bring multiple stakeholders together. So the question is, does anybody care about it? Some researchers do, but he's got 15 or 20 communities that seem to be interested in actually trying this thing. So I think there are some people who care about it, and there may be some ways to overcome the wrong pockets problem.
Yeah.
I just want to reassure you that there are people who care about it, but also note that my understanding of the Nichols and Taylor approach sort of assumes that there is a backbone organization who can play this role of pulling all of the, being that trusted broker. And so it is something that I think we hope we're developing, again, through our Accountable Health Communities model, but that thinking about how we foster those entities is a really important part of where we go from here.
And one final question then, maybe before we open it up to the floor. Is there a way of framing these questions that are the wrong pocket questions that that you think will be most effective in terms of making the case that it doesn't matter if it's the wrong pocket, it is the right thing to do because of the benefits that result?
I think that that's a way to frame it to altruistic investors. But I think that there are some investors who really do care about the financial return. And for them, that may matter, but it may not be enough to get them to play.
Well, thank you. I see people lining up. So, Seth, please begin.
Hi, Seth Berkowitz from UNC. I want to go back to John's idea about the double standard in this case. I don't think health-related social needs interventions are the only sector in healthcare where this exists. I mean, behavioral health, obviously, I think prevention in general is known to get sort of short shrift in some ways. But I do think there is a particular preeminence of somewhat narrowly defined financial ROI as a consideration in health-related social needs intervention. And so I have, I guess, a three-part question. Why is that wise? And if it's not wise, what could we do to help change that?
So I think that, again, this is a value-based payment frameworks are a tremendous opportunity that has provided a lot of lift to this kind of work, but they are also like what is the analogy, a golden prison or something like that, right? Like the golden handcuffs, thank you. But because, on the one hand, they have caused all of these entities, including CMS, to be very interested in what kinds of evidence-based interventions we can use to generate value, which we define as basically quality over cost. But, that framework potentially excludes lots of things that would generate tremendous value considered in a broader paradigm. And I think that there is, potentially lots of room for different ways of thinking about that. But it's going to have to come from external stakeholders who help put the pieces together in different ways, because we, at least speaking at the federal level, are all operating, within the bounds of our particular statutory constraints. But I'm also going to run with your question to share a different but I think related concern, which is that I think there has been a sense that under a lot of these different value-based frameworks, people were going to do the sort of easy stuff first. They were going to do high utilizers, and then there would be some point at which they would get to these other kinds of interventions. And I think we are seeing some of that as we build capacity to do different kinds of interventions and different kinds of community partnerships and drive value. But we also see sectors of healthcare, outpatient and prescription drug costs in particular, that are rising so rapidly that it is sort of like there's always some new thing that's very expensive on the healthcare side, where much of healthcare is going to be spending its time trying to address that thing. And so I think it makes it even more important that if our goal is not just to reduce costs, but really is to drive improvements in health, that we find ways of making sure that we spotlight that, because there is this constant threat of the kind of whack-a-mole of healthcare dollars that we're always going to be trying to put out the fire of an area where costs are growing.
Yes, to our next question, please. Yes.
My name is Demdi Elias. I'm a local DC physician. And I think you probably answered part of the question, the concept of the wrong pockets. And maybe the concept should not be pockets. Maybe the concept should be something altruistic. But I still think, as what Dr. Miller referred to, that people really do care about money. And that seems to be the overriding thing. And that makes sense because, we're in a capitalistic society. So I like the concept of the Nichols economic model, and maybe that will have some traction. But I guess there's no really clear answer to the wrong pockets problem. It's kind of what we're hearing, except the possible economic model.
The answer that has typically been used in the past has been, well, that's a role, therefore, for government spending. Mm-hmm. What I think Nichols is trying to do is say maybe there's a way that one can do this without involving the government investing in this. We'll see how well that works.
When you get the answer, tell us.
I think that at the federal level, what I can remember being told that given the constraints in CMS can't, because there are limits in terms of what it can consider given its statutory authority. And so we were told OMB would be the place, because in OMB you would be able to have some a portion of government which would have some oversight over other areas. I know I worked for a governor before, and for a governor, in theory, you could be making the case of spending more in one part of the budget would get you a savings in another part of the budget. But I would tell you, as someone who worked for a governor, that's a very hard argument to make, in part because you're essentially saying that your colleague who heads another agency should have his or her budget cut, because in order for your budget to increase. And so there's just a lot of social pressures, I think, against that. It really takes some really mission-driven leadership to be able to say, on the part of a governor or a leadership, I'm going to do that. I'm going to make those hard decisions, on the hope that happens.
So what I'm hearing is possibly our efforts should be put on ensuring that everybody has the right mission. Because when we all leave here, we're going to obviously continue to do what we're doing in our own spaces. But then I just think, is it advocacy? We think on a political level, what is it? What is going to move the needle a little bit faster?
So let me ask the question maybe that I think you're asking. I think maybe you're asking, is a policy change, is this about a policy that change, and could it be made at what level, federal, state, local? Or is it about more research? Is there some additional research that might provide an answer that would make it easier to? So why don't I ask the panelists there? Do you think that is there is there a policy that could be put in place at a federal, state, or local level? Or is there a gap in research that, if we could fill that, might be helpful in terms of addressing this question?
You got it.
And I don't know that I'm going to address it in full. I mean, so the wrong pockets comes into place when there are silos of money, or the money is distributed, separately. So again, ideally, if you could get to whoever is distributing the money, like wherever the central pot of money is before it gets distributed, and that entity, again, can manage where the money goes and where the pockets are. And so that's where you get into things like braided and blended funding streams that can be really helpful. I'm a child psychiatrist. We have this issue a lot with kids who are getting services from, education, child protective services, juvenile justice, Medicaid, and the developmental disabilities sort of public funding as well. And so, when there are these separate entities, then you have that fighting, and any investment you want to do here, if the savings are over here, this entity is not going to do it, right? But if you can join that funding, because ultimately upstream, it is one pot of money, right? If you can figure out a way to join it, then you can relieve some of those divisions. But that's sort of one sort of immediate scale, but you're talking on the federal government scale. I mean, it gets bigger and bigger as you go along. And then the other piece is that point about the research. I get pretty jaded, again, from my experience in behavioral health. We've got the research. We know it's effective. We've done the ROI. We know it's cost effective, and still that's not enough. And I do think it's a lot about the advocacy, so convincing the policymakers. I think capitalizing on when we have leaders like CEOs or who are dedicated to really capitalize and get the work done there and demonstrate it, and maybe they can be that voice to show that this is important, and then it can spread.
Thank you.
And I think, I would add, I know it may not be happening fast enough, but it is happening right now. And I think the fact that the Assistant Secretary for Health, convened this meeting, the level of interest, the level at which, that's happening at a federal policymaking level. There is a lot happening. That I will put in a plug for the Integrated Care for Kids model, which was designed to facilitate exactly that kind of local braiding. I do also think, though, that this is, in the many cases, an area where we are not where we are with behavioral health or with some other aspects of prevention, where we have some evidence, but we don't have all of the evidence that we would want. And I think there is a strong role for additional research. I frequently tell this story that when we were designing the Accountable Health Communities model, we work really closely with our CMS Office of the Actuary, and they put a high value on published evidence and peer-reviewed, and ideally RCTs with utilization or cost as the outcome. And we sent them a paper that was in Health Affairs, and one of the questions that they came back with was about a footnote in Table 2, being it looks like this cell is what's really driving this, and is that what you guys think that you're going to see in the model? And so, I know it's not always apparent to the outside, but we really are paying attention to the research. We really use it. And so I think that is an important part of the solution as we move forward.
Does any particular gap come to mind as an area where if some research could be done in this particular area, maybe just as an example, that might be useful research?
I mean, there are so many, and I will just note that about a week ago, I tweeted a request for anyone that had, several people here retweeted, but I did not get them any answers about interventions that, where there was intervention data on utilization and costs. But, I think we have bright spots around medically tailored meals, around some of the things that we heard about earlier, but they often have been in narrowly defined populations, without again often various kinds of different outcomes that are not utilization and costs, pre-post, all the issues that we've talked about earlier today. So I think we are looking across the spectrum of housing, transportation, food, social isolation. It's all on the table. We're trying to learn, and so keep it coming.
George. you're a researcher. What do you think?
I agree that we need more research. Is that self-serving? I think we don't, although I think we understand that there are some determinants that are highly important. I mean, we were talking about housing and food insecurity today. I think everybody agrees those are pretty important. I don't think there are others, particularly more upstream determinants that interact more complexly with each other that we don't fully understand. We know that education and income, for example, both are correlated with health. Education and income are also correlated with each other. And so where's the causation there? I think if we understood those things better, we would have a better idea of where we should be focusing our investments. With regard to those investments themselves, I think that we also need more research on which ones work. What is the better way to improve education, for example, or to increase the availability of affordable housing? And finally, I think we need more research also into how to get people to invest in these things once we understand where the investment should go. I agree with you that even about the things that we know we ought to be investing in, we're still having a difficult time getting them funded.
Hi, Kelly Doran from NYU School of Medicine. As a researcher, Don, your comments made my heart sing. And I just retweeted your tweet about needing more research. But getting to some of the difficulties of ROI, and this touches upon another comment, but I specifically wanted to ask, given these challenges, what you see as the potential role of regulation specifically around the healthcare system that might encourage more investment in social needs. One of the panelists mentioned earlier today, for example, putting regulations around how hospitals spend their community benefit dollars. I wanted to hear what you thought of that idea and any other ideas you have.
So Mark, can I say, is the presumption there you really can't make the argument around return on investment, so it's just you have to just force the decision? Is that
not necessarily? I do actually believe that there is some ROI argument to be made, although to use Dave Chukchi's words, I'm not quite like bullish on that necessarily, but I do think there is some argument to be made, but I think we should be thinking about other types of persuasions as well.
So I will continue to plug CMS and note that folks should check out this related because of the regulatory piece, a few payment rules that we put out last week that included a proposal for a standardized set of questions, particularly in post-acute, I think skilled nursing and a few other settings that include a transportation question. And so I know there's a lot of both interest and concern about exactly how specific CMS is going to be in terms of the types of social needs data that folks collect. But this is an area that is rapidly evolving and where there is work happening right now. I think one challenge that I would put back for anyone here is to think about what the exact kind of regulatory proposals that you would contemplate in terms of, again, thinking about the level of specificity that we typically engage in and, whether it's about community benefit or anything else, if we were to put in place requirements, what would those be? If we talk about evidence-based interventions or the kinds of health outcomes that we're aiming for, how would we, codify those? And I think that actually gets back to where the research is needed because it kind of drives to the questions where there are still uncertainties.
This is not regulation, but I do see promise in the value-based payment arrangements and getting more health systems towards that tipping point where the bulk of their payments are in more of these sort of global or capitated arrangements. And I've just experienced that personally. I've been a part of about 3 ACO systems as they venture into this more heading toward capitation space. And that's where I really see a shift in terms of looking at health, looking at cost, and trying to get to those drivers. And then I see those investments in behavioral health coming and more of the social determinants and social needs interventions. And I've really just seen that palpably in my own experience in these health systems. And so I think that is I do think there's promise in how we pay for the care.
Dan?
I guess I'm trying to thread some pieces together here, and because I want to, get a little more optimistic after hearing all the challenges in really leveraging value-based payment for making the investments that I think many people here in the room, understand, bring so much value to communities. But within the narrow window of value-based payment and return on investment for these, entities that fall within these payment models, it's a very different question that we'd be trying to answer than this infrastructure that's been in place for generations that are delivering social, programs. Been going on for a long time that I think everyone's convinced that we don't care if there's a return on it. People should eat. People should have housing. And that's kind of how this infrastructure is built. So there's a cultural clash. And so that also gets to the lack of research on these particular very targeted interventions, because we're asking for the research among, a kind of a body of people who have worked under a different financing model. So then I guess I'm left to asking the question, what's the value of value-based payment for social determinants of health? And I guess we wouldn't be here if it wasn't. And I guess it reminds me of the Al Capone thing. I'll probably butcher this, but why does he rob banks? It's where the money is. And I think that's why it's worth this conversation. This is so important, because that last dollar spent on health does not deliver health. That last dollar we spend on food delivers a lot of, feeds a belly that needs to be fed. That last dollar we spend on housing gets someone housed that doesn't have housing. So that's why we're having this conversation. So I would like, us to think about how to unleash, and I think with the next session about research that really gets at these targeted. What we need for we really need a better evidence base. We started putting this session together, there'll be lots of evidence. People to bring and say, my ROI is this, and there's just not a lot out there within the context of value-based payment. Because it comes within a context that a lot of people working in this area just are unfamiliar with, or maybe resist because of the kind of place they come from. But I think it's worth going after just because of, we can bring value if we can redistribute money, but we really have to answer the question, how do we target an intervention within this framework, even if we don't really like the framework? So that's more of a little speech than a question, but I'd be happy to hear some remarks.
Some of us like the framework.
Maybe what I would say, what your comments made me think of is that when the initial discussions, I think, around return on investment started in terms of value-based contracting, they often started at looking at the most expensive patients, the most complex patients, the ones who were driving up premium costs. And for whom there was a willingness to do some experimentation about whether for those patients, if you did an intervention, that was unconventional, could you prove a return on investment? And I think at least some of that research, I'm thinking of Seth's research, showed that the population, as the research took place, it turned out it wasn't such a small segment after all. There were actually other patients that weren't only the high-cost patients, that also there were some savings. So any thoughts about that, the sort of starting with the low-hanging fruit maybe? In your experience, has that been an easier place to get innovation?
That's the approach that I'm taking, is if you're having trouble, if you've got an organization that is bought into the healthcare system as it is and believes that, we don't need to prove the ROI on this surgery, but we certainly do need to prove the ROI on this social intervention. Well, start with the low-hanging fruit and work within that context, get some buy-in, and then potentially you could go on and get deeper. It's not perfect, but it is a starting place.
Is there an example where that has worked in your insurance company?
Yeah, so that's basically the approach that I've taken with our strategy. Is I think that in terms of behavioral health, and when you're looking at a population, there are some low-hanging fruits. There's some populations where that are big populations that are driving the bulk of the poor health and the high cost, Also for those populations, we have evidence-based interventions that if we can get those interventions to those populations, you're more likely to see the return in terms of health and cost. And so if I can, new to the space, new on the block, begin to garner some of those successes, potentially I'll be able to push going further with more. So.
I guess I've become very pessimistic that there is any low-hanging fruit. I think just one lesson from many of our CMMI models has been that often, change is hard and it takes time, and many interventions actually show a slight uptick in costs in the first year before, you're getting folks into care that maybe weren't before, and then you have a decline over time. One of these depressing comments that motivates me was from an ACO that was actually dropping out of our Million Hearts cardiovascular risk reduction model and said, I have a limited amount of quality improvement dollars and I can get more bang for the buck out of putting them into reducing CHF and AMI readmissions than I can into preventing first-time heart attack and stroke. I mean, this is horrifying. And yes, I'm seeing all the, we know how to prevent heart attack and stroke, and it is not happening at anywhere near the level that we should be seeing it. And, I think that is a problem that kind of turns back to us and says, we have structured the incentives, poorly. And so I think Stacy might have been the person who said earlier, I believe economics works. But I think, kind of low-hanging fruit or not, I think one of the most important things for us is getting the incentives right, because I do think that the incentives will drive behavior.
Can you give an example of where you think they were done right?
I mean, I think right now we are putting a very strong emphasis on reducing hospitalizations, and I think that is a place where we see a lot of opportunity to address both short and long-term incentives and prevent not just the rehospitalizations, but the first-time hospitalizations. And I do think, and maybe this is where the low-hanging fruit argument is more salient, some of that same infrastructure that hospitals have set up to reduce readmissions, for example, may be very relevant to reducing. And this is something we are seeing. Okay, thank you. You've talked me back to a more optimistic place. But in our Maryland, model, we are seeing hospitals that are under a global budget really engage, again, some of that infrastructure that they've created around reducing readmissions to try to drive down first-time admissions. So I think that is one example.
Good. Oh, yes.
The only thing that I would add is that, health systems, there is a limited budget for these interventions. And so sometimes you do have to figure out what are the lowest hanging, if I have to make a choice with the money that I have, with the investment that I have, where am I going to see the biggest bang? And I saw that in our Medicaid program. I worked with a Medicaid MCO, totally bought into social determinants. We were walking the walk. And our savings, we invested in housing, but our savings were minuscule, because we were operating on such a small margin. And so, yes, we invested in housing, but nowhere at the level where, we would be getting it at the dose and to really meet the need of this population and see the return in terms of health and cost that we were looking for. And so I think it's legitimate. There's limited dollars. And so how can we make the most use out of those dollars?
Yes. Stacey.
Yeah, so we have, the pharmaceutical industry comes to mind as one that hasn't been mentioned today, with a stake in all of this. And I'm, back to Dawn's point about the things people say that just make you so depressed. And for me, it was, if we don't take care of sick enough, poor enough and sick enough women, we won't fill our NICU. There was a study I did of HIV-infected mothers who were giving birth to they've given birth to more than one baby HIV exposed. And they were so marginalized that they said HIV is the best thing that ever happened to me. Because all of a sudden they belonged somewhere, they had a place to go for care, they had the wraparound services. And some of what Dawn is saying, the diabetes criteria for DPP had to be stricter because it's only for those people you can show the return that warrants the payment. So this is all a problem. Now the pharmaceutical industry has an interest in keeping sick people alive as long as possible to continue to consume the drug. They also have to conduct clinical research, and they contract with clinical research organizations that are based in the poorest communities. And in the course of conducting research, they identify unmet needs, and they need those needs addressed for the person to continue on in the clinical trial. So there have been some very nice ideas shared about the other levers we need to pull in order to keep moving in this direction. And I wonder if you've thought at all about how, or has anyone thought about how the pharmaceutical industry could be better engaged?
I don't see anybody commenting on that, but I think a lot of nodding heads. So I think we have time for one more question, and then we're going to ask two of our panelists, not three, what recommendations they would make around federal policy, just as a part of the closing comments. I think you can surmise which of the two I'm going to ask. So please.
Hi, Larry McNeely, American Diabetes Association. Quick, maybe trying to figure out all the wrong pockets isn't the only strategy here, or figure out how we get the ROI in this year for an intervention that saves 10 years. What about the choices that folks make about quality metrics? Obviously, you get behavior change because of some of the quality metrics for readmissions, but then some things that were built onto that. I'd be interested in perspectives on, obviously we're a long ways to go. We don't even have one for DPP that's broadly utilized in DPP referral and uptake. But I'm interested in folks' reaction to that. Thank you.
You're asking, can a quality measure
Right.
motivate you to
that changes the ROI,
that
right?
changes the ROI.
If you have a quality measure in certain
Got it.
systems, right? Stars.
Well, if you have a quality measure that has some teeth behind it, right? And I think that goes back to an earlier question about regulation. Yeah, regulation around quality metrics, I think, can play a role here.
George, then, Helen, any closing thoughts if you were advising the federal government about a policy to consider that would be helpful in this regard?
I think this is already beginning to happen, but I think that loosening up restrictions within both Medicare and Medicaid on what constitutes an appropriate investment, and you probably have more to say about that, on the way that those funds can be spent beyond direct health care to encompass some of the social determinants. And as I say, I think there's some that are already happening, but I think more of that would be helpful.
Thank you. Catherine?
I thought you were going to ask her.
I know.
Now I got to think for a second. I think I do think more around how, and I don't have an answer to this, but yeah, how do we change the incentives to where we switch to where health and prevention are the focus, and so whatever the policies and the regulations that are needed to be put into place to make that happen, I think when you turn the current system on its head and you make health the important outcome, that's where you get the emphasis on these things that we're focused on.
Yeah. Dawn, this isn't about federal policy, but any closing thoughts you have about this topic?
Thank you. I think we are learning a lot being here today, and I want to sort of maybe shine one more light, actually, in response to the quality question, because I think this actually ties together, at least from a CMS perspective, some of the themes that also came up in the previous panel, including around accountability, and so we, for example, I'm going to go back to Maryland as the beacon, but in Maryland are working with the state right now on the population health credits that are part of their total cost of care model, in which we will actually be in an agreement with the state around essentially allowing them to keep a larger part of their savings based on bringing down the prevalence of diabetes in the state. So that's very exciting and remarkable, but is also something that we can't typically do at, say, the practice level. From a just validity and reliability perspective of measures, it would not make sense to pay providers based on, the incidence of diabetes in their patient populations. And so this really gets at how do we think about who's accountable, how do we structure, we want to pay for outcomes, but what are the right outcomes to pay for? And thus I will bring it back to our request for information about geographic accountability. But I think, this is an area where we are continuing to learn and definitely welcome folks' thoughts on how we continue to structure incentives to make them the best on both quality measurement and payment.
Well, as a representative of CMS, let me say thank you for the changes that have been made. You've been highlighting those, but they really have, I think, opened the door for a greater incorporation of social determinants into payments. So thank you, and thank you for the work you're doing at CMMI. So please join me in thanking the panel. They did a terrific job. And now we're going to take a 10-minute. We're going to take a 10-minute break, and we'll reconvene at 3:45. Thank you.